This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Hi, we have a very interesting case. 22-year-old lady has come with this clinical picture. She has nystagmus. She was operated for congenital cataract many years back, probably when she was 2 years old. And she has this optic capture with the lens. Both eyes are pseudophakic, and in the other eye the refraction is about -8 spherical, and the best corrected visual acuity is 6/60 with the full correction of glasses. In this eye with best correction, the vision is CF 1 meter, and she wishes to have better vision in this eye. We are unable to get a good autorefraction reading in this patient because the pupil is occluded and there is an optic capture. There is a fibrotic membrane covering the pupillary margin. Previous records do suggest that refraction was similar to the other eye, which is around -8 spherical. Now, this is a challenging situation and we need to think from multiple aspects here. So, the points to consider intervention is the patient definitely does want to have a better vision in this eye, and also we need to clear the visual axis to see the retina for any future problems. So, what are the points to consider? Number one, now should we consider explantation of the lens and put in a new lens? Well, that can be possible theoretically. At the same time, it is much more traumatic to the eye considering this is more pathological. And I'm not sure whether it's a PMMA lens or a foldable lens because there are no records available for it. And if we have to correct the residual refractive error, that would be the best option. However, in that scenario, the other eye, which is having relatively better vision, will also have to be taken care of since that also has a -8 spherical. The second option would be just to put the lens back in its place and deal with this fibrotic membrane. Because basically you're trying to correct this optic capture and clear the visual axis. That is an alternative, and you have to keep the lens as it is. Now with the same pre-existing lens correction, she can just move around. So these are the pros and cons which we discussed with the patient, and the patient was more interested in just dealing with the left eye and not to have any surgical correction in the right eye. So that meant that we need to just fix this IOL and put it back in place and then try to deal with this, the overlying fibrotic membrane. And the patient said she was happy wearing the glasses and she wouldn't mind that. Lens exchange for refractive correction may be considered as a later option. Now, how do you plan surgery for this eye in this patient? Now, you need to remember that this patient is pathological myopia, so we need to be mindful of that. So the first thing would be you can always try a laser capsulotomy as well, but the membranes would be so thick that it might be very difficult to penetrate it, and we may end up using a lot of energy, and which might not be the best way to deal, especially when you are dealing with an eye who has pathological myopia. My plan would be to make 2 paracentesis incision, keep my vitrector ready, fill in the chamber with OVD, and then try to dial the lens back behind the pupil and then cut and take care of this fibrotic membrane. Let's see how things turn up. So I'm making these 2 1 mm paracentesis incisions on either side. Cohesive OVD is placed into the eye, and I begin by using an iris spatula. The iris spatula, I'm just trying to separate this posterior synechia, this fibrotic band which is sticking onto the lens. And as I'm trying to do this, thankfully for me, the lens just slips back behind the pupil. So the optic capture was relieved without much of an effort at all. So what I'm left now is an overlying fibrotic membrane. And at this stage, I'm not seeing any evidence of any vitreous disturbance. Although since the pupil is not dilated well enough, I cannot rule out the presence of a pre-existing posterior capsular tear. At this stage, there doesn't seem to be any vitreous. Now, how do we cut this fibrotic membrane? I thought I would like to use an micro scissors and make a nick and then try to peel it off with a micro forceps. As I'm trying to do, unfortunately, none of the scissors seems to be strong enough to cut this fibrotic band. So I changed multiple scissors, but I was unsuccessful. Finally, I thought the best device to take care of this would be the vitrector. So I'm going to use the vitrector to cut it. I'm going to use the setting of IA cut with a linear cut rate and a low vacuum and flow rate so that I can really control what I am cutting here. So as the instruments enter the eye, I just like to point out that the bottle height which are kept is again quite low. So these eyes have got low scleral rigidity, so I just don't want to go with a very high bottle rate. And then the cutting is begun. The port is held up and I'm trying to engage this fibrotic membrane and cut. It's important to be mindful that our cutter has to be new, fresh, so that it cuts well. So thankfully for me, the vitrector did work, and in a couple of minutes, the fibrotic membrane was cleared off. I thought I would like to dial the lens in. The lens doesn't seem to be sitting pretty well. Use the Synskyoke to dial the lens about 90 degrees and it looks to be slightly better. Here at this stage, I'm seeing this demarcation line, and probably this is the question mark pre-existing posterior capsular tear, and I need to be mindful of this. So I'm just going with my cutter and look for any presence of any vitreous. There seem to be none. And before closing, I thought I would like to go ahead and do a small peripheral iridectomy. I performed this with the same cutter itself, using the irrigation, aspiration and cut mode, using very low cut rate, and we have a nice little iridectomy done here. Time to close. Now before coming out, with the irrigation still on, I go in and hydrate the side port incision. The other side port is also hydrated. So at the beginning it looked a little bit complex case, but I could manage this with just 2 paracentesis incisions. Important thing to know that we should be prepared for the worst case scenarios, but sometimes you never know, we end up being lucky and the case would not become so difficult as we anticipated it to be. These are the post-op pictures. This is the first day post-op picture, and these are the third day post-op pictures. The patient's best corrected visual acuity in this eye is now again 660, which is similar to that eye, and the patient is relatively happy. The patient did undergo a dilated retinal evaluation and will continue to do so in the coming 3 to 6 months. So that was it. Thank you for watching. Hope you found this helpful.